So my objective is to indicate how relatively recent cardiac surgery has developed, to identify some of the names you may have heard of, and to demonstrate that this was one of the first medical endeavors that required a team, and then some of the lessons I've learned from reviewing this. I have no disclosures. What strikes me is that basically this history all occurred in my lifetime. When I was born, there was no surgical treatment for congenital or valvular heart disease. While I was just starting out in grade school, there was no surgery for cyanotic heart disease. At the time I was a senior in high school, there was no open heart surgery. When I graduated from med school, there were no prosthetic heart valves or pacemakers. When I finished my surgery training as a cardiac surgeon, there was no cabbages or heart transplants or arterial switch operations or balloon pumps or PA catheters. When I came here, UK, 30 years ago, their internal mammary grafting wasn't done. There was no TEE, no ECMO, no propofol, no protein. So it's a young history from my perspective. Now, like everything, it didn't start de novo. There were lots of preparations ahead of time that were all necessary to allow cardiac surgery to develop, and I've just listed some of these on this slide. Blood typing and transfusion, discovery of heparin and protamine, endotracheal tubes, modern anesthetics, vascular surgery techniques, all were necessary before this could have happened. But between 38 and 52, closed heart surgery really came into being. And it began in 1938, August 26, when Dr. Gross first successfully ligated a patent ductus arteriosus. Anesthesia was provided by a nurse using cyclopropane and a mask. At that time, Gross was a surgery resident, and he did this operation when his chief was on vacation. In the old days, the chief would go away for 2 months for summer vacation, and while he was gone, Gross did this operation because when his chief left, he said, "Don't do this operation." They had been studying it in the lab. He said, "Don't do this operation while I'm gone." And so he did it. Anyway, the next dramatic operation was accomplished November 1944, the so-called Blalock-Taussig operation, or the blue baby operation for cyanotic heart disease. The anastomosis of the subclavian artery to the pulmonary artery to improve pulmonary blood flow in patients with tetralogy of Fallot. Helen Taussig thought of this operation and recommended it, and Blalock was a surgeon at Johns Hopkins who she suggested that he do this operation. The first attempt was, as I said, and fortunately the patient survived. And what is interesting is anesthesia was provided by ether, by mask, by Merle Harmel, who was a first-year resident at that time, 6 months into his training. He later became chair of anesthesia at Duke, and there's a chairmanship named after him. He just died a couple years ago. Following that case, they did 55 in the first year, 20% mortality, and by the end of 1950, they had done over 1,000 cases, and mortality had dropped to 5%. This was the first report of that operation, done a few months later in JAMA, and this was a 15-month-old, 4-kilo baby in which they did this. And unlike many surgical reports nowadays, you notice that right in the first paragraph, he mentioned that anesthesia was provided and named the person who provided that. And I mentioned these were the resident, and Lamont was the attending, and I guess he thought it was such a hopeless procedure that he might as well have the resident do it. You see in the first 100 cases, mortality was 23%. And they wrote the first paper on cardiac anesthesia that appeared in Anesthesiology in 1946. Dr. Brock, who also was one of the early surgeons in Great Britain doing these operations, emphasized that it required a team to provide this. And he summarized the anesthetic technique they were using in London. But I emphasize here, no ECG, no arterial or central line, no pulse oximetry, no capnograph, no recovery room, no ICU. Patients were extubated in the OR. The mortality, as I said, at Johns Hopkins, first 100 cases, 23. At Chicago, in their first 125 cases, mortality was 3%, without any of this stuff. The next big advance occurred in 1948. After 20 years of no progress, I didn't mention, but this had been attempted in the 1920s with no success. And then after 20 years, for some reason, within 3 months, 3 different surgeons in 2 different countries succeeded in doing closed mitral commissiotomy. First, Charles Bailey on June 10th, and then Dwight Harkins at Boston 6 days later, and then Dr. Brock in London a couple months later. These are the 3 surgeons who accomplished this. So that was the start of closed heart surgery, a procedure that we continued to do. I did as a surgeon closed mitral commissiotomies in the 60s. But it was a real breakthrough that surgery could not only treat congenital heart disease, but also acquired heart disease. But they were still seeking some way to do open heart surgery, and there were some innovative approaches. And one was by Robert Gross, the guy who did the first patent ductus, who used the atrial well. And basically what they did, they sewed this funnel onto the atrium, and then working blindly only by feel, they would reach inside and close atrial septal defects. But the notable advance occurred in September of 1952 when John Lewis, a surgeon at the University of Minnesota, did the first successful direct vision open heart surgery using moderate hypothermia without cardiopulmonary bypass. They would cool the patient down to about 30 degrees, open the chest, occlude the cavity to cause circulatory arrest, open the heart, and do the repair within 5 to 10 minutes, and then restore circulation. This operation followed the work of Dr. Bigelow of Toronto, who studied this in animals and proved that it was successful, but he could never get any cardiologist to refer patients to him, so he didn't get to realize the success that Dr. Lewis did. Interesting, Dr. Bailey, the guy who did the first successful mitral commissiotomy, had actually attempted to close an ASD a week before, but that patient died in the OR. So as I mentioned, we remember Lewis because his was successful, and forget Bailey who did it, but unfortunately the patient didn't survive. The major stumbling block, however, for the search of a heart-lung machine was to develop an oxygenator. The pump was no problem, but how to get an oxygenator that was successful. And this search had been going on for more than 100 years, and all sorts of different things had been attempted. But it was finally accomplished in May of 1953 by John Gibbon, which was the culmination of an amazing story. This is a picture of Dr. Gibbon in his older age. He was professor of surgery at Jefferson. In 1930, when he was a resident in Boston, he was charged with watching a patient who had a pulmonary embolus, and they were waiting to do the Trendelenburg operation. This was a crash pulmonary embolectomy without bypass, in which you would open the chest, open the PA, pull the clots out, close it without any bypass, without any hypothermia. And actually, it had been successfully used in a few cases. And he was charged to watch this lady until she arrested, and then call the team to do the procedure. And while he was watching there with this lady with the cyanosis and distended neck veins, it occurred to him that if he could take the blood out of the veins and oxygenate it and put it back into the arteries, that he could save her life. And so he suggests this to his chief, and he says, everyone has thought of that. It's a stupid idea. It can't be done. Forget about it. Well, he didn't take this advice, and he started working on it, and continued to work on it. And by 1939, in his animal studies, he was having cats that were surviving for up to 15 minutes of bypass with his machine. Like a lot of surgery research at that time, it was interrupted by World War II. He was in the military service. He then came back in 1946 and had a fortuitous relationship with the founder of IBM, who offered his engineers to work with him in developing the heart-lung machine. And by 1952, he had 90% survivors of canine survivors of up to an hour of bypass, and felt he was ready to try this in humans. Unfortunately, the first attempt was a failure because of the wrong diagnosis. The patient didn't have an ASD, had a PDA. As a consequence, he sent his residents down to a place that was doing this new procedure called cardiac catheterization, and learned how to properly diagnose this. And he then did this second attempt 20 years after he started this research, and successfully closed an ASD. This was the heart-lung machine that he developed along with IBM. The patient was an 18-year-old, had 26 minutes of full bypass, 45 minutes of total bypass. Arterial pressure was measured with a mercury manometer connected with a needle to the brachial artery. The other venous access were 2 ankle veins. Anesthesia was provided by a nurse. It apparently solely consisted of 2 grams of pentothal and manual ventilation. Apparently the endotracheal tube was placed by some physician. We don't know who that was, what his skills were or whatever. 1 hour after the procedure, the patient was awake in her bed in the ICU. Very important. On the ward, there were no ICUs. This is a picture of that first operation. This is a total anesthetic record. They charted the blood pressure. They charted the heart rate. What's interesting to me is he and IBM invented this machine. They patented, but they gave the plans freely to anyone who wanted to do it. They patented to protect it from being abused. They earned no profit. He felt it was part of his academic career to develop things. It's so different nowadays, where we emphasize how we need to patent these things and get money back to the institution. He thought that was immoral. I still think it's immoral, but anyway. Unfortunately, he had 2 subsequent failures, and he gave up on the procedure. And his resident at the time at Canadian, we're going to mention a lot of Canadians, mentioned that at Jefferson, the lack of expertise in anesthesia, pediatric cardiology, pathology, all played a part in this initial failures, emphasizing the essential role of a complete team to accomplish cardiac surgery. Over the next couple of years, there was only one other successful operation using a heart-lung machine, despite 20 attempts by 7 different groups. And a lot of the problems were wrong diagnosis, excessive blood return, and air embolization. Some hypothesized that unlike animals, where they were having regular success with bypass, that human subjects were too sick to undergo cardiopulmonary bypass. And in fact, Gibbons offered to lead a ban on the use of open heart surgery in the United States. But fortunately, this didn't deter others from continuing this work. And this succeeded then in 1955. But it began with this remarkable experiment, if you will, by Dr. Lillihei at University of Minnesota, called cross circulation. What he thought of was that he could use another human or animal as a heart-lung machine and use cross circulation with low flows. And so he first tested this in animals, and then he applied it in patients. So basically, you connected the patient, a child, to an adult. The child's venous system was connected to the venous system of the donor, and the donor's arterial system was connected to the arterial system of the patient. And so the adult donor acted like the heart-lung machine for the patient. He did between 55 and excuse me, 54 and 55. He did this procedure on 45 patients. Fortunately, the first patient survived, and they did direct vision open heart surgery by this method. These were major operations. There were 27 VSDs, 10 tetralogies, and 5 AV canals, with 2/3 of the patients surviving. What this procedure documented was that it dispelled the concept that these children were too sick to tolerate cardiopulmonary bypass, and demonstrated the potential for cardiopulmonary bypass to permit open heart surgery if a satisfactory heart-lung machine and a method of using it could be developed and used by a talented team. And that talented team occurred just 90 miles south of where Lillihei worked. Lillihei was at Minneapolis, and John Kirkland was at the Mayo Clinic in Rochester, Minnesota. John Kirkland was a surgeon, a young surgeon at that institution, and he embarked on a systematic attempt to conduct open heart surgery with a heart-lung machine. First, he reviewed all of the workers, and they made visits all over the country and the world to look at what people were doing. And they decided that the best machine was the one that Gibbons had developed. And so Gibbons offered the plans, and they modified the machine and then studied it in animals until they were sure that they could do it. And then they planned a research study of 8 patients and said, we're going to do this on 8 patients, rather they live or die, and see if this can work, recognizing that one failure and causing it to stop would not be correct. They needed to do a large enough study to see if in fact there was hope for this. And so they started this on March 22nd, and it went through May, using the Mayo modification of the Gibbon IBM heart-lung machine. The team included Dr. Swan, who was a cardiologist. You know him as the inventor of the Swan-Ganz catheter. He went to UCLA at that time, went to Southern California, and Robert Patrick, who was the anesthesiologist on that first series. They did 4 VSDs, 2 AV canals, 1 tetralogy, and an ASD. Half of them survived. Sounds terrible, but this was the first group of, remember, prior to this time, there had been only 2 survivors in the whole world. And so 50% survival, although in your minds sounded terrible, this was a great advance. And remember, these were hopelessly ill patients. They had no future. They were going to die. they were generally small, most of them under 10 kilos. This was a very modern system they used, full flows, open cardiotomy, venous saturation was monitored, arterial saturation was monitored on the heart-lung machine, better than maybe we do right now. This is a picture of one of their first cases. This is the modified heart-lung machine that they used. Shortly thereafter, Dr. Lillihei, after having one of his physicians on his team develop another oxygenator, started a series using their heart-lung machine. This was the Lillihei DeWaal bubble oxygenator machine that they used, they did this on 7 patients, 4 of whom survived. By the fall of 1955, regularly scheduled open heart surgery with a heart-lung machine was being conducted at only 2 places in the world. Both were in Minnesota, 90 miles apart, Mayo Clinic under John Kirkland and University of Wisconsin, Minnesota under Lillihei. By that fall, Mayo Clinic had done 40 cases, 93% survival in their last 14, and Lillihei had done 36 cases with nearly 90% survival in their last 19 cases. As a postscript, 30 years after John Gibbons started his search for a heart-lung machine to treat pulmonary embolism, Dr. Sharp and Dr. Cooley at Johns Hopkins in Houston successfully used the heart-lung machine to perform pulmonary embolectomies. And then 60 years later, Davies in 1995 described the use of veno-arterial ECMO as the definitive treatment of pulmonary embolism, reaching John Gibbons' original aim in 1930 to treat pulmonary embolism with a pump oxygenator. In 1956, Dr. Cowan wrote the first textbook of anesthesia for the heart. There were a number of other developments in the last part of the 1950s, which I've summarized on here. But the explosive development of cardiac surgery occurred in 1960. This is when I started my career right after I graduated from medical school. And the key things here were replacement of heart valves, coronary artery bypass surgery, heart transplant, congenital heart surgery, and advanced in bypass. Now, all of these occurred in this decade of 60 to 70. The first was prosthetic heart valves. Dr. Harkin suggested putting a cage ball valve in the subaortic position. He had one success, but not really any regular success, and a lot of people thought that was hopeless. But in 1960 and 61, Dr. Starr and Edwards reported consistent success, first with a mitral valve prosthesis and then with an aortic valve prosthesis, and this really made prosthetic valves possible. This is a picture of Dr. Edwards and Dr. Starr. Dr. Edwards at that time was a 60-year-old retired engineer, professor at University of Oregon. And Dr. Starr was a brand new cardiac surgeon from, I think, Columbia, who went out to this, to the West. You know, that was the Wild West. Hardly anything was being done there, to start his program at University of Oregon. Well, Dr. Edwards came to Dr. Starr shortly after he arrived, and he said, I'd like to build an artificial heart. And Dr. Starr said, well, that's a bold idea, but maybe you should start with just developing an artificial heart valve. We don't even have that yet. And lo and behold, Dr. Edwards did. And he developed these ball valves, which were the first consistently successful heart valves. And more than, I say 175, probably more than 200,000 of these were implanted over the next 30 years. The last were produced in Asia in 2008. They're no longer used. But I've seen patients 25 years later with these valves in place. There were many other advances then in prosthetic heart valves that are summarized here. The next great advance during the 1960s was coronary artery surgery. This was initiated by Dr. Weinberg, another Canadian, who invented the operation of internal mammary implant. He would implant a bare bleeding internal mammary into the myocardium, not connected to the blood vessel, and he had documented in animal studies that this would develop collaterals into the circulatory system. It didn't improve blood flow a lot, but it improved it somewhat. And in fact, this was a very popular operation, and it led to the first article on anesthesia for coronary artery surgery by Earl Winans, who worked with Dr. Weinberg. And they described how they provided anesthesia for these critically ill patients with coronary artery disease. But the big step was when Dr. Favellaro, a young surgeon at Cleveland Clinic, introduced the use of saphenous vein for aortocoronary bypass. However, he applied it in only a few patients with right coronary artery disease. And in my opinion, it was really Dudley Johnson at Milwaukee who really popularized this operation. Because what he did, and he just died the last couple of months, was present a series of 120 patients in whom he applied multiple grafts to all of the coronary arteries, not just the right coronary, and used a heart-lung machine to accomplish this, including intermittent aortic cross-clamping to provide a quiet field. This was a notable thing because, as I said, Favellaro had only thought it was applicable in a few patients. And what Dr. Johnson demonstrated was that most patients with coronary artery disease could be benefited from this operation. And Dr. Spencer, who happened to be the first chief of cardiac surgery at University of Kentucky, but notable leader in this field, he stood up and discussed this, and he said, we may have heard a milestone in cardiac surgery because for years, pathologists and cardiologists thought that we couldn't treat coronary artery disease surgically. And he said, if this exciting data by Dr. Johnson remains valid, a total revision of our thinking will be required regarding the feasibility of direct coronary artery surgery for coronary artery disease. And as you know, the rest is history. Now, the internal mammary graft, as you know, is what is standard nowadays. But this was rejected by most surgeons. They thought, including Favellaro, who thought it was too difficult, that the vessel was too small, and it was unnecessary. However, one of the young surgeons at the Cleveland Clinic, Floyd Loop, adopted it and did a large series of patients. And in 1985 and 86, they published a report in New England Journal showing the vastly superior outcome, long-term outcome, 5 years, 10 years, of using internal mammary grafts versus coronary versus saphenous vein. And following that article, it was widely adopted. And in fact, when I started here in 87, I started here in 84. In 86, when Dr. Sakella was a resident in cardiac surgery, he and his professor, Dr. Todd, who was chief at that time, first started to use internal mammaries here at University of Kentucky. The third monumental introduction in the 60s was heart transplantation. Alexis Carrel first documented this feasible in animals, but it was really Norm Shumway who started research in the early 60s, and by the late 60s was reporting long-term survival in dogs with heart transplantation, and was ready to do human patients when appropriate candidates and donors became available. However, it was Christian Barnard at Cape Town who really did the first such procedure. This was Dr. Shumway, picture of him as a young surgeon at Stanford, also trained at Minnesota, went out to California, and was hired on at Stanford when they moved down to Palo Alto, and did this research, including describing how to do the transplant. And this remained the standard operation, although nowadays, instead of a single atrial anastomosis, using bicaval anastomosis is popular. But until the last 10 years, the Shumway technique, which he developed in 1960, was how all heart transplants were done. But the first successful human transplant was done by Christian Barnard at Cape Town on December 3rd. This procedure was done with little, quote, modern techniques. Monitoring was only a blood pressure cuff, one lead ECG, a water manometer on the IVC, and a urinary catheter and temperature. No arterial blood pressure, oximeter, capnograph, arterial line, TEE, PA catheter, etc. They induced with pentothal and gave muscle relaxant. Only gave 25 milligrams of pyridine. No synthetic narcotics, etomidate. Used a bubble oxygenator, roller pump. Patient was weaned off bypass, infusions of only isoprel and lidocaine. This is his anesthetic record for this first heart transplant. This is a picture of the patient a few days after his transplant. This, I think, holds the record for the most rapid publication of any clinical study. It was published 27 days after the procedure, but unfortunately 10 days after the patient died. The patient died 17 days post-op. They thought of rejection, that he was having rejection. They gave him steroids. It turned out he had fungal endocarditis. Fungal pneumonia, and died of infection. In retrospect, he was a terrible candidate. He had peripheral vascular disease, diabetes, severe ascites, pulmonary edema, cellulitis, phlebitis, and severe pulmonary hypertension. We would not have done this patient nowadays. But they were not daunted by this initial failure. 1 month later, they did their second, and that patient lived for 18 months and died of a new entity that they had never heard of before, graft coronary vasculopathy. Their third patient lived for 18 years. Unfortunately, their work stimulated a stampede of Me Too operations. And in the following year, 102 transplants were done in 52 centers in 17 different countries. In Norman Shumway's word, heart transplants were being done in places where no one would hesitate, when one would hesitate to have their atrial septal defect closed. Unfortunately, a third of these were dead within 8 days, and only a third were alive at the end of a year, with a mean survival of 54 days. And this shows what was going on. You see in that first year a huge bump, and then it tapered down, and there were only 4 groups that continued to investigate this. The Barnard at Cape Town, Cabral in Paris, Lauer at Virginia, and Shumway at Stanford. Shumway continued to work. This shows their progressive improvement over years. But most notably, they were given access to cyclosporin in 78. They began a study which showed a dramatic improvement in long-term survival, and this led to the explosive growth of transplantation, starting in 1983 when cyclosporin was released for general use. There were also many advances in congenital heart surgery, which I won't review today, but they're in my expanded version on Wiki. There were a number of developments in cardiopulmonary bypass, including the appearance of perfusionists, membrane oxygenators, centrifugal pumps, arterial filters, heparin bonded circuits. There were also other important advances in cardiac medicine. Selective coronary angiography by Sones in '59, closed massage by Cowenhoven, implantable pacemakers in 1960, the use of halophane for cardiac surgery at Mayo Clinic and just north of us, Indiana, Stolting, father, and monitoring left atrial pressure. Other advances were anti-impulse therapy for aortic dissection, intra-aortic balloon pump, narcotic anesthesia by Lowenstein in '69, pulmonary artery catheter you know about, and intensive care units, modern ICU ventilators, blood gases, etc. Cold cardioplegia in '73, heparin and protamine dosing using the ACT by Bull at Loma Linda in '75, and then efficient membrane oxygenator. One of the most notable things, however, was an article that appeared at February 4th, 1978 by an unknown cardiologist in Switzerland named Andreas Grunzig. And he described balloon dilatation of coronary artery disease. What's remarkable is one of his cases was left main, and which was sort of considered in subsequent years a contraindication for this. But as you know, this revolutionized the medical treatment of coronary artery disease based on this study of 5 patients. A lot of other changes in the 80s. Heart transplant, as I said, became common. Artificial heart was started to develop. Internal mammary arteries were adopted. Neonatal surgery was become routinely successful in pediatric cardiac surgery center, and transcatheter procedures. Cardiopulmonary bypass was advanced. There were other advances in the 90s. But one of the important things was the development of interventional or transcatheter surgery. This was first described by Rashkin at Schock when he invented atrial septostomy, which is a palliative procedure for transposition of the great arteries, in which he would pass a catheter through the interatrial septum, inflate a balloon, and pull it back, rupture the atrial septum to allow adequate mixing to relieve the cyanosis. Kantrowitz developed the balloon pump, a arterial method of assistance. Grunzig described balloon angioplasty, and then many other advances, as you know, in interventional or transcatheter surgery, leading nowadays to TAVR and coming next week, the mitral valve implantations percutaneously. These are 2 of the giants, I think. Rashkin, I mentioned, he was the one who started this in 1960. Dr. Locke's brother, who was at Minnesota and now at Children's Hospital, was instrumental in leading to the development of the atrial septal occluder to treat ASDs, which is now used for all sorts of things, as well as all the other pediatric devices. He's really the inventor and developer of all of those devices. Another big advance was echocardiography. Dr. Klimkina and I wrote a review of this in a previous edition of Kaplan's. This just briefly describes the history. What's important, back in '76, Paul Barish used transthoracic echo to evaluate the effects of anesthetic on patients. The group in New York described using M-mode TEE during anesthesia. But the real advance was Cahalan and his colleagues in '82, who used a TEE probe brought over from Germany and documented what beautiful pictures it would provide. And cardiologists had rejected this, but when they saw the work of Cahalan and all, suddenly they grasped onto it. And so really anesthesiology introduced TEE to the American cardiologists. And as you know, this is now a defining characteristic of cardiac anesthesiologists. There have been many advances in cardiac anesthesia. Use of pulmonary artery catheter, monitoring the V5, use of nitroglycerin, use of high-dose synthetic narcotics like fentanyl by Stanley. Fellowship training programs occurred. Some of the early ones, and then societies were developed. The first was the Association of Cardiac Anesthesiologists, but then the Society for Cardiovascular Anesthesiologists in '78. And then the first comprehensive textbook in cardiac anesthesia was published by Dr. Kaplan in 1979. If you're interested in history, Dr. Tice wrote this nice review of the 30 years of the development of cardiac anesthesia. Some of the developments in cardiac anesthesia include TE, I mentioned, so-called isoflurane steel. Slogoff and Keats described the importance of perioperative ischemia. Moffitt and Sethna. Moffitt was Dr. Murphy's teacher at Dalhousie. Described anesthesia in coronary circulation. Nitric oxide was described. In 1987, the Journal of Cardiothoracic Anesthesia was initiated by Dr. Kaplan, and et cetera. Cardiac anesthesia, cardiac anesthesiologists have become leaders in anesthesia. They've become chairs of departments and deans of colleges. They've collaborated with other specialties in various ways. They have educational symposium, new textbooks, and on cardiac anesthesia, and textbooks on cardiopulmonary bypass, including Gravely's, which just came out this year. Anesthesia, cardiac anesthesiology has been involved in very important research activities in many different areas. Cardiac anesthesia became a specialty, subspecialty, requiring special knowledge, special techniques, special monitoring, etc. Now, you could argue, when did it become a subspecialty? One could say in 1946, when Harmel and Lamont wrote the first paper on anesthesia, or when Cowan wrote the first textbook on cardiac anesthesia, or when fellowships occurred, or when the societies developed, when Kaplan's textbook came out. But still, it's not an ABMS recognized subspecialty, although fellowship training are now recognized, and as you know, we'll start ours in less than a month. Cardiac anesthesia has made many contributions to the practice of non-cardiac anesthesia, including all of this monitoring. We really introduced it, or by we I meant cardiac anesthesia. They they discovered the importance of perioperative ischemia. They brought critical care into the operating room, conversely led to the development of intensive care units and the application of all sorts of cardiovascular drugs, which first came out of cardiac anesthesia. I'd like to just mention some of the important leaders. Dr. Cowan, I've already mentioned. He was a participant in Dr. Bailey's first successful mitral commissurotomy. He wrote the first paper on anesthesia for mitral commissurotomy and published the first textbook. Emerson Moffitt, as I mentioned, he was Canadian. He went to Mayo Clinic and was part of their team of the early studies and papers on anesthesia for cardiopulmonary bypass, and was co-founder of the Association of Cardiac Anesthesiologists and studied extensively, of which Dr. Murphy participated, of the effects of various anesthetics on myocardial oxygen balance in patients. Edward Lowenstein at MGH, who introduced high-dose narcotic anesthesia, co-founder of important organizations, started the notorious fellowship, I mean in a good way, of cardiac anesthesia, one of the first at MGH, and was a student of ethics and anesthesia. Earl Winans, I mentioned, he collaborated with Weinberg with internal mammary artery implant procedures, wrote the first article on anesthesia for coronary artery surgery, co-founder of organizations and president of the Society of Cardiovascular Anesthesia. I believe he's still living, and received the Canadian Medal, is it called?
Yeah, Order of Canada.
Order of Canada, the only, I think, anesthesiologist to receive that order. Michael Cahalan, who was a young anesthesiologist at UCSF who introduced TEE to the cardiology in the rest of the world, and was just recently the chairman at University of Utah. Dennis Mangano, who is in some minds a pariah, in other minds a great contributor. I consider him a great contributor. He really initiated multi-center research, popularized prophylactic beta blockers, and called attention to the risk of a protein, which ultimately led to its removal from our use. Joel Kaplan, who I believe is responsible for making this a specialty. He popularized it. He was a young anesthesiologist at Emory, emphasized what a great specialty this was, and stimulated many of us to enter this specialty. He also published the first definitive volumetric volume on cardiac anesthesia, and the first journal exclusively devoted to cardiac anesthesia. He also introduced the use of PA catheters, nitroglycerin infusion, monitoring V5, etc., etc. Dan Tice, one of the leaders in echocardiography and the development of boards and subspecialty certification. Massive changes over the last 40 years. This shows the first textbook and the 5th edition now in its 8th edition. What a big change from 100 pages to 1,200 pages, etc. In reviewing this history, I raised the question: are we so much better than our predecessors? We think we are, but think back. This is the group at Chicago Memorial. The surgeon was Potts. The anesthesiologist was McQuiston. They did 347 closures of PDAs with no deaths. In 1950, the group at Hospital of Sick Children, Toronto, the surgeon Mustard, the anesthesiologist Kahn, 63 consecutive closures of secundum ASDs with hypothermia alone, no deaths. In 1963-64, the surgeon Magoon and his anesthesiologist Moffat reported 100 consecutive aortic valve replacements, no deaths. These were done with no coronary angio, no cold cardioplegia, no pulmonary artery cath, no ergo, no pulse oximeter, no narcotic anesthesia, no membrane oxygen, no centrifugal pump, nothing that we think is essential, and they had 100 cases with no death. They were good clinicians. What have I learned from this review? I think you learn a lot from reviewing history. It's been an international effort. The great innovators have had brilliance, determination, creativity, and courage to do it. But it's not only the innovators, it's the patients who had the courage to accept these risks and made it possible for these advances. The near simultaneous accomplishments of surgical breakthroughs. Why these things all occurred in lumps. Serendipity plays a part. The thin line from success to failure. Perseverance is important. Remember Bailey, 3 years working on mitral commissure. Mustard, 10 years on treating transposition. Weinberg, 15 years on his implant. And Gibbon, 23 years to develop a heart-lung machine. Reassess, but don't abandon sound procedures. Re-examine the status quo. Take another look at discarded procedures. Beware of rejecting new ideas. Don't get discouraged if you don't get to train where you want to. Laboratory work is important. Clinic advances are dependent on basic research, which initially had no apparent practical application, but in time they were instrumental. The interaction of those in other disciplines and in other countries. Youth doesn't preclude success. McLean was a medical student when he invented heparin. Gross, a surgery resident when he ligated PDA. Gibbon constructed his first heart-lung machine as a resident. Harmel was a first-year resident when he provided anesthesia for Blaylock. Cowan has just completed his residency. He was 32 years old when he collaborated with Bailey on the first successful mitral commissurotomy. Kirkland, Lillihei, and Starr were all young faculty members in their 30s. DeWall and Jarvik were young laboratory assistants when they invented their heart-lung machine and artificial hearts. But age doesn't preclude possibility. Cowan was 75, retired engineer, when he introduced closed chest massage. And Edwards was 60-year-old retired engineer when he developed prosthetic heart valves. Competition can spur success. Creative environment stimulates success. Johns Hopkins University was a breeding point of great cardiac surgeons, as was the University of Minnesota. And finally, we stand on the shoulder of giants. Dr. Brock, one of the leading developers of closed heart surgery in London, emphasized that these operations are tiring and anxious procedures involving much care and responsibility and hard work. Fortunately, they have their happier side, and we are in large part compensated for these long and difficult hours by seeing almost miraculous change in children themselves, witnessing the joy and relief of the parents when they see their children are running happily like other children. In closing, we have only witnessed the beginning of our history. At the 25th anniversary of Kirkland's first successful series of open heart surgery, he mentioned, "We could, of course, rejoice at our accomplishments and accept that no idea that nature has set, that there is no, that there are limits to what we can accept." Bill Wath in 1897 said that cardiac surgery had reached its limits. In 1954, people urged the aborting of pump oxygenator effort, but he persisted. Not the passage of time, but efforts of many people have proven these ideas to be wrong, and I believe acceptance of such an idea today would be wrong. So we've only reviewed the beginning, and you guys are going to live through a remarkable change in the practice over the next 70 years, as I have been honored to watch in my life. Thank you.
Thank you. That was fantastic.
There's be a